We spend at Mass General Brigham about $1.25 billion a year, how we file it in our taxes, and we track it for the Attorney General here on those mission components, on care for the underserved, on discretionary investments in community health, on covering unreimbursed components of research and education for medical professions of the future, things that are focused on the patients of today or the patients of tomorrow. But it's not enough to just say, well, we invest $1.25 billion. Right? That would be like a for-profit company saying, hey, our ROI is that, we're building a new product and we're going to spend a lot of money on it. What's your return going to be? Well, we're spending $1 billion to develop it. It's like, wait, you would never let that pass in the boardroom of a Fortune 500 company. Why do we let that pass in our industry?
Welcome to A&M Healthcare Industry Group's What's Your Moonshot podcast series, where world-class healthcare leaders seek to solve big problems. Listen as we talk to today's health system CEOs about the journey to achieve their moonshots.
Welcome to A&M's What's Your Moonshot podcast series. I am John Coyle, a Managing Director in A&M's Healthcare Industry Group. I'm joined by my co-hosts today, Donna Houlne and Bujnowski, fellow Managing Directors in the Healthcare Industry Group at A&M. Today, we're thrilled to have Niyum Gandhi on our podcast. Niyum is the Chief Financial Officer and Treasurer at Massachusetts General Brigham. In his role, Niyum is guiding massive investments in the mission of this prestigious integrated health system, which is the largest employer in New England and the largest medical research organization in the world. Niyum has spent half his career in health system CFO roles. Previously, Niyum served as a CFO for Mount Sinai Health System in New York City. Prior to that, Niyum was a partner and healthcare leader for a global consulting firm. Welcome, Niyum, and we're looking forward to a great discussion.
Thanks so much, Sean. And thanks, Donna. Thanks, Aaron. Great to be with you all.
Great to be here with you.
Yes.
So let's jump right in. Niyum, tell us about your moonshot, specifically your role in guiding over $1 billion a year of investments in the various aspects of the MGB mission.
Thanks, John. This is something that, and I do think of it as a moonshot because we're maybe a couple of years into a many-year journey to kind of rethink how we define ROI as a not-for-profit health system, how we think about a return on investment, specifically related to the mission. And this it's an idea that I've been kind of thinking about going back to my time at Mount Sinai and that I discussed with some colleagues and some board members there. And I think we've been able to make some good progress here at Mass General Brigham, which is really thinking about the return on our investment and our mission in terms of the outcomes that we deliver for our shareholders. And as a not-for-profit, here in New England, our shareholders are quite literally and legally the people of the Commonwealth of Massachusetts and Southern New Hampshire. We aren't a for-profit company with shareholders who buy common stock and look for earnings per share. The earnings per share that we deliver to these people is actual outcomes on the areas of our mission focus: care for the underserved, research, education, community health. And I think historically, the not-for-profit health system industry has just kind of quantified that mission in dollars. We spend at Mass General Brigham about $1.25 billion a year per how we file it in our taxes, and we track it for the Attorney General here on those mission components, on care for the underserved, on discretionary investments in community health, on covering unreimbursed components of research and education for medical professions of the future. They're all things that are focused on the patients of today or the patients of tomorrow. But it's not enough to just say, well, we invest $1.25 billion. Right? That would be like a for-profit company saying, hey, our ROI is that, we're building a new product and we're going to spend a lot of money on it. It's like, well, what's your return going to be? Well, we're spending $1 billion to develop it. It's like, wait, you would never let that pass in the boardroom of a Fortune 500 company. Why do we let that pass in our industry? Just saying we spend $1.25 billion. And so what we're on kind of a mission to do, no pun intended there, is really shift the narrative and say, what are we buying for that in terms of health outcomes, in terms of research outcomes, in terms of education outcomes for the people who we serve? And again, as I mentioned, we're a couple of years into this. We've got a lot of work still ahead of us, but it's starting to change the narrative and change the way that we actually make those investments, prioritize those investments, and do the things that we need to do for the people that we serve.
So Niyum, when you think about those investments, you don't have to get into a lot of specifics, but you're really doing it at a massive scale. It's fairly impressive. right? So when you think about this idea of return and you think about this idea of the investment, like what goes into your decision heuristic? How do you decide about those investments? How do you decide how you move and how you scale to get the kind of return you're thinking about?
So this, I think, has been the biggest shift, Aaron, that the way we used to make them, maybe I'll say the way we used to make those decisions and the way we do now, the way we used to, I think like many other health systems, was very bottom up. And our chief medical officer often describes it as it used to be kind of a sprinkling strategy. Hey, there's a good program here, give it a little bit of money, see what impact we can have. Good program here, So then you actually lose all of that. And I like that you framed it as scale. You lose all of that scale benefit because it's disparate, it's not linked. And yes, we're doing great little things, but we aren't able to say over a multi-year period, we're going to have a certain trajectory and outcome. So now what we're doing is we're picking specific metrics that we want to move the needle on. So I'll give an example, and it's the one that we're furthest along on is community health. So in the community that we serve, there is a 12-year mortality gap between our white patients and our Latino and Black patients in our communities, right? That's unconscionable, right? That is not equity in health outcomes. Okay, so what do we want to do? We want to cut that gap in half first, and we have a target to do that by 2040, and then eventually eliminate it altogether. All right, so if we're going to do that, how do we prioritize? Well, first we need to know what drives the gap. 9 years of the 12 years of gap are driven by cardiometabolic disease. Okay, almost the entire rest of it are driven by maternal mortality and easily screenable cancers. So that's where we're going to focus that, right? So can we make our hundreds of millions of dollars in community health in a way that is structured and built around processes that will reliably deliver the outcome of reducing excess mortality, rather than just saying, this seems like a good program, let's invest in it. And so getting to an outcome metric first, defining the process that will get us to that, and then investing in the structures necessary to enable those processes to get to the outcome. That's how we're shifting our decision-making as it relates to these investments in mission.
Very impressive.
A quick question. ROI is a very interesting term to be used for nonprofit institution like, Mass General, Brigham's. You touched a little bit about your mission, and you gave us a couple of examples of where that's happening, which is, I applaud you, having, been a clinician there for 20 years. What are some of the other areas that you are looking for returns in each of your particular mission areas? How many missions are you really looking at changing over the span of the next 10, 15 years?
So the way I think about it is, and most academic health systems have, what they call either a tripartite or quadripartite mission, clinical care, community health, research, education. Sometimes they blend the first two. I like to think about it, and I borrowed this from one of my colleagues here, who frames it as the patients of today and the patients of tomorrow, right? And so I would say the mission is lives saved, right? We are here as an organization with one purpose: to improve human health. Okay. And I like that you called it out, Donna, that ROI is kind of an interesting and maybe a little counterintuitive term for a not-for-profit health system. For a for-profit organization, really simple. I is in dollars, R is in dollars. Currency is the same. If you can invest $1 and generate $2, positive ROI. So if we can invest, I'll go back to our community health mission example. If we invest $200 million in discretionary community health programming a year, which we did last year, and we believe that a sustained investment of that will cut that mortality gap, from 12 years to 6 years. So that's thousands of lives saved. Can we look at ourselves and say, yeah, that's a good return on investment? Yeah, probably. If we could spend an extra $1 million and cut that gap, another 20%, would we do it? Of course. What if we had to spend $10 billion to just save another life or two? We probably wouldn't, right? And so that creates some tension then, right? You're not trying to take a financial currency and translate it to a lives saved currency. And the same thing is true in whether you're doing it in community health or in education, training the next generation of clinicians and clinician scientists to have impact at scale. If we can do that incrementally better by investing $300 million instead of $280 million a year, maybe. If we had to invest $1 billion or $2 billion and bankrupt the whole system, probably not. We're still working through, you kind of asked, how do we define it? The macro is we're trying to get to things that relate to lives saved, a lot more straightforward for the patients of today. We have quality metrics, we have outcome metrics we can look at. What are the lives saved by supporting the research of, Gary Ruvkin, who just won the Nobel Prize in medicine as a Mass General Hospital researcher? I don't know. I'm assuming quite a bit, but how many years from now on which patients of tomorrow versus what about translational research that actually gets a clinical trial into a patient tomorrow on a novel gene therapy? Well, maybe fewer lives saved, but much more immediate and much more certain. And so again, I don't think there's a clear, perfect way to do it, but by saying that the return is going to be an improvement in human health, it at least allows us to focus the conversation.
Yes, thank you.
And Niyum, this is fascinating. It's ambitious. Can you just give us a little bit of a sense of what it's like putting this into practice in your organization on a day-to-day basis?
So it sounds, sounds nice when we frame it this way. I think that the rubber meets the road in two ways, in terms of putting it into practice. One is actually, Donna, related to your question of how do you define it? So how precisely do we define, where do we get there? So the community health mission, we got pretty specific. We set a goal on how we want to close the mortality gap. We quantified that in terms of lives saved. Same thing with our quality journey. All of our investments that we've made recently in inpatient quality, we actually just reported out on it to one of our boards. Our chief medical officer was showing the chart over the last 2 years. The specific investments we made in quality reduced our inpatient mortality enough to have saved 1,400 lives. Right? That's great. No risk adjustment piece to that or whatever else. Yeah, the risk of the patients actually went up at the same time, but just straight observed mortality decreased enough, driven by putting in an early warning system, some of the other investments that we've made, rethinking how we think about patient care progression, et cetera, to do that. Okay, so some of it easy to define, some of it a little harder to define. That's one of the things, where the rubber meets the road on putting it into practice. I'd say the other more challenging one, and this one's a little tougher to navigate and sometimes tough to talk about, is money is finite. So, how do you think about, if you're going to invest something more in one area, do you have to cut back somewhere else? How do you start making trade-offs between individual programs? And I think that's something where, again, we've had to do some of that in some of our areas, but more challenges there to come. But we use this narrative to focus the conversation when we think about investments, whether they be annual investments in the budgeting process, whether they be multi-year investments. Our CMO would, if you had him here, would say, when he was launching the whole quality journey and community health journey, the question I asked him most often was, it sounds great. What am I buying? Like, what is the outcome I'm buying? Which is very different. It's a shift from advocacy to accountability. And I think that's typically the missionary conversations were about advocacy. Give me more, which I recognize maybe means giving somebody else less, or the prevailing perspective that there are gold bars somewhere in the basement and there's, unlimited money. But it was an advocacy. Give me more and I'll do things with it. Instead, it's, okay, we'll give you more. And what outcome are you signing up for with that?
So being, a clinician and always thinking about the patient, how am I, if I'm a patient in one of your facilities, how am I going to notice that my patient experience is going to differ in this approach today versus when I was a patient 4 or 5 years ago? How would I know that as a patient?
What it should drive is a better experience across all of the outcome metrics that are important to you, informed by the best learning we have at any given point in time. Because again, that kind of shift from advocacy to accountability, if we say we're signing up for a reduction in inpatient mortality, I guess you should notice that by having a lower likelihood of dying in the hospital, which is probably a great patient experience living. But again, I'll pick on the community health one. What you should see is actually, the only way we're going to move the needle on equitable outcomes is by thinking about investments in socially disadvantaged communities in a differential way. So then you should notice that people are thinking more about the needs that you have that could drive early mortality and closing those gaps, and recognizing that that may be different for somebody who is living in Dorchester than somebody living in the South End. And so I think taken to its logical conclusion, again, if you say the outcome is what we want to move, that's what we're buying, you need a process to get that outcome. You need structures to support those processes. The patients see the structures and the processes. Actually, they see the processes the most. What they want is the outcome, but they should see the processes being more tailored and more specific at driving a desirable outcome, again, improvement of human health, than just kind of what an individual clinician might be passionate about, which is not to say that the individual clinician's passion is unimportant. It is incredibly important. And as we think about investing an incremental dollar, we are here for our patients, our shareholders, right? And so we have an obligation to put that against the thing that is most likely to deliver the best outcome.
To make this maybe really real for our listeners here, you mentioned something I think was important. You talked about one of the execution challenges you have, which is the trade-off of investment, because there's many different opportunities to invest and you have to make that trade-off. What are some of the other things that you would tell our listeners, like these are the real execution challenges that you have to face when you're doing something like this? And then what have you done to overcome those challenges?
So maybe just going another beat on trade-offs, I'll make it come alive with an example. When our chief community health officer and chief medical officer defined our journey around health equity, and we looked at that data on what's driving excess mortality, and we found how much of it was cardiometabolic disease. So we stood up a whole bunch of programs related to cardiometabolic disease. We don't have unlimited money, right? So as we thought about community health workers, as an example, did we add community health workers? Yes. But also, we had community health workers working on pediatric asthma. If an hour of a community health worker focusing on prediabetes care or hypertension care saves more lives than an hour of a community health worker on pediatric asthma, in addition to adding whatever we can afford to add, should we also redeploy that person? Yeah, absolutely. And that's what we did. And there's some people who are not very happy about that, right? And so that is hard, right? And so I think that it's where it really comes alive for our chief medical officer and chief community health officer to go to those people and say, we're going to reduce your funding. We're going to cut some of these resources so that we can invest it in a place where we're going to have more impact on human health and save more lives. We do that on financial decisions all the time, right? It's really easy to say, well, we're shrinking this, whatever initiative, or, think about it if you were some other sort of company, consumer packaged goods company, tech company, right? Apple says, oh, we aren't making enough money on, whatever, Macs, we're going to invest more in iPhones. Nobody cares, right? They say, oh, I like that program, but yeah, we'll make more money over here. When you start saying pediatric asthma, a little less investment so we can focus on adult cardiometabolic health, because it increases our odds of achieving our goal, which is to eliminate the black-white mortality gap. All right, that gets real very quickly. So that's one of the implementation challenges. I think the other thing that goes along with that is then who makes those decisions? And in an advocacy model, what you typically have is a lot of bottom-up requests, and then somebody who's not terribly equipped to make those decisions, me, CFO saying yes and no. In an accountability framework, you actually have somebody who owns the mission area. So I mentioned our CMO a number of times. Tom Sequist is his name. He's brilliant. He makes those decisions, right? He's the one sitting with the people running one program saying, we're going to reduce here and increase there, because he knows that there's a finite pool of investment in community health. He knows that we collectively, the board, the CEO, my team does the measurement, is holding him accountable for achieving that goal, holding all of us accountable for working together. So he's got to say, yeah, $1 million less here and $1 million more here increases our likelihood of meeting it. And so defining who the owner is, how much authority they have, what the decision rights are, what the policies and procedures are around that. Yeah, I've picked on the community health example because we're so much further along on that one. Research is a great one where we're not far along at all on it. We're just starting to have these conversations with our department chairs, with our chief academic officer. Again, it's kind of an example, translational research versus basic science. Well, both really important. Are we going to think about trade-offs there? Or maybe we aren't. right? Maybe we're going to say that the way science progresses is by letting 1,000 flowers bloom. But if we let 1,000 flowers bloom, should we also invest in maybe a tended garden and a greenhouse for the flowers that we think are most promising to have impact on human health at scale? Yeah, we should, right? And then the trade-off decisions around that, who makes those decisions? Not me, right? I would say shouldn't be, but it requires rewiring a lot of how decisions are made in the organization at lower levels and at more senior levels. And I think and it requires incredible patience amongst all stakeholders to do that work. And I think that's the other big implementation challenge, which is why we're not done, right? And I don't think this will never be perfect, but for it even to get to something that drives daily decisions in all 4 of our mission areas, I think we're another 5 years away from it.
As you look across the industry and considering the increasing scarcity of investment funds, how might this way of thinking about ROI influence other health systems?
I think that scarcity is at an all-time high, right? 2022 was the worst financial year in history for 76% of licensed hospitals. Not in a decade, not into ever. And 2023 was the second worst year for the industry. And I think 24, when the books are all closed, will probably be the third worst for the industry. So it's tough, right? This industry was not built for inflation. We have rapid growth in cost of living per people, which means rapid growth in wages, which makes sense. And, we have limited resources in which to invest in an aging population that increasingly needs more care. All right. So scarcity is real and is worse than it was 5 years ago, 10 years ago, 20 years ago. With that, I would say I find this view of ROI. So I've had this conversation with some other folks. I had this conversation once with the CFO of a for-profit health system where he said, it's like, I think your job's harder than mine. And, because of how you guys need to think about serving multiple missions. And he's like, mine's a little bit more simpler. I was like, actually, I think yours is harder than mine. He laughed. He's like, okay, that's good. It's good that I'm in my job and you're in your job then. And I said, well, no, I think the reason yours is harder is because in times of scarcity, you need to think about how to make money. And it's harder and harder to make money. I need to think about the best way to lose money. And I find that much more fulfilling. And so taking this definition of ROI, I actually think is liberating, because in an advocacy-based model, you end up being the CF no, right? The person who's just like, great, I have 1,000 advocates coming to me. There's less money. Last year, I said yes to 100. I said no to 900. This year, I got to say no to 920 and say yes to 80 because there's less money. If you take an accountability-based frame, you actually get to say yes if, right, instead of no because. And so hopefully, and as I talk to counterparts at other large not-for-profit health systems, they're all going through their version of this. This is by no means unique to Mass General Brigham. We're all kind of having this shift to, all right, yes, with accountability allows us, especially in times of scarcity, to have the impact we want to without really cutting back on the impact that the organization can have, despite the scarcity of input resources.
Thank you so much for taking time to share your moonshot with us. It's incredible to hear about this journey you're leading organization through, from advocacy to accountability and commitment to outcomes. It sounds rather wonderful to be able to have that different kind of conversation in times of increasing scarcity. And I'm sure a lot of people are going to get some real value out of hearing your perspective on this, and Godspeed on your moonshot. Thank you.
Thank you.
Alvarez and Marcel. Leadership, action, results.